can discuss inside. Good morning.
Good morning.
Hi, I'm Murat Tuzcu. My co-moderator is Dr. Byung-Hee. And then let me introduce you our distinguished panel, if I may. Adrian Chung and Elena Elashchinov, Dr. Hayashida, Dr. Won-Yang Kim, Dr. Hanchel Lee, Dr. Sewan Lee, Dr. Lefebvre, Dr. Walters, Darren Walters, and Wojciechowski. We welcome you, and then Mike is yours.
Can you hear me?
Very well.
Hello everyone. I am Kiyuk Chang, interventional cardiologist of Seoul St. Mary Hospital. Good to see you again, Dr. Kentaro, and Dr. Kim and Dr. Lee. First of all, I'd like to introduce my team. Just next to me, Dr. Yoon Seok. The second guy is Dr. Byung-Hee Hwang. And then today, tea is going on by Dr. Woo-Baek Chung. And then the anesthesiologist is Dr. Ho. So the today's case is very interesting. We prepared several discussion points. Before going on TAVI, the doctor will present the case briefly.
Okay. Let me introduce patient information. Patient is 84-year-old female. Chief complaint was aggravated dyspnea, DIA class 3 dyspnea. In past history, she underwent PCI 10 years ago, and 5 years ago she suffered ischemic stroke and underwent carotid artery stenting. So STH score was 7.4%. Next. She have hypertension. Next. This is transthoracic echocardiography. Severe aortic stenosis. The Vmax is 4.5 meter per sec. Mean pressure gradient is 61 millimeter mercury. Aortic valve area of 0.8 or 0.9. Would you introduce T finding, Dr. Chung?
Okay, this is aortic valve of TEE. So there is several calcified nodules on non-coronary cusps. So paravalvular leak may occur around this area. So to reduce paravalvular leak, we need to decide whether to pre-balloon or not.
So as you can see, T, the RCC and NCC has very severe calcium, especially RCC has a lot of calcium. So please understand this. Next.
Next. This is a CT finding. The perimeter is 76.2 millimeter.
We do not. Okay, here we go. Go ahead.
Previous area is 4.18 square centimeter. Next. This is calcium distribution. The calcium distribution is relatively even among three cusps. However, the amount of calcium is moderate to severe and relatively horizontal aorta. However, there was no calcification in LVOT. Next. This is peripheral CT angiogram. The iliac artery and femoral artery is sufficient for transfemoral approach. However, the left EIA, there is a severe calcification, and the device is, we are going to TAVI device by right femoral. Next. This is coronary angiogram. We undergo coronary angiogram yesterday. the moderate stenosis in proximal to be the LAD, and moderate stenosis in proximal Seok, and severe stenosis is distal Seok. Next. This is FFR, the result of FFR. The FFR of LAD is 0.77. The FFR of OM was 0.68, and FFR of Seok was 0.79. Next. Okay, we plan to TAVI by evolute R 29 millimeters. Next. This is our discussion point. First, whether a strategy is better, on-site PCI during TAVI versus TAVI after elective scheduled PCI. Second is the relevance of FFR in patients with severe AS. So this main discussion point. These patients have very severe amount of calcification of 3 cause. In the case, and evolute which strategy is better, pre-ballooning versus direct stent implantation? Okay. Finally, how to make coaxiality during implantation in horizontal aorta?
Before the procedure, we are planning minimalist TAVI procedure. However, the patient has a lot of calcium in right coronary curve and non-coronary curve. So we change our policy because we are concerned about the paravalvular leak after implantation. So right now she underwent general anesthesia and T was inserted. In this patient, 2 points. You can believe FFR in patient with severe aortic stenosis, and do you prefer pre-ballooning in patient with severe AS who are going to receive the evolute R, not Sapien 3? So my discussion point is like this. Please, the panel discussion, and let me know.
Well, that's great. Thank you very much for the elegant presentation and already making our life easy with pointing out the discussion points. Indeed, perhaps we can even add another discussion point, that do we need to do the revascularization before proceeding with TAVR? So let me ask the panelists to comment on the issue of coronary disease and if they think that PCI should be done, should it be done at the same stage or should be staged? Darren, what would you do?
Well, if there's significant proximal epicardial stenosis, I think we routinely revascularize them ahead of the TAVI procedure. It unnecessarily complicates the TAVI procedure, affects the whole flow of the case list for the day. So we find it simpler to electively revascularize where we need to, and then implant in a staged fashion. Prefer not to try to revascularize after implantation of a stent, particularly through the side strut, say, of a core valve or other. You can't always be guaranteed of good access. And so I think if you know, patient that have coronary stenoses, it's very simple to schedule this in, have it done as a part of a preparation for transcatheter valve replacement. While it is possible, and we have done combined procedures, it really does interrupt the whole flow of the patient for the day.
Any other comments?
Just one comment, maybe. Anyone?
I fully agree with what was said just before. I think it's when we have critical lesion of the proximal vessel, I always treat it. We have not seen the lesion, so I think it's very important also to see if it's critical or not. But looking at the FFR, it looks very severe. So I will do it before the TAVI, but not during the same hospital stay, in order to avoid accumulation of contrast.
I think based on the angiogram, just a quicker look at it, really quicker, but based on anatomically, I'm not impressed with critical stenosis on the angiogram. And at our center, I think we changed a lot. So at the beginning, we are pretty aggressive to fix the coronary artery stenosis before the TAVI. But now we are most time we don't do it. unless patient is once symptomatic or significant, clearly have angina and also have a significant stenosis in the larger arteries, or the really like a big main artery with a critical stenosis. Otherwise, we are leave alone. Seems like there's no really issues.
Interesting. I tend to agree with Dr. Ye, because we also say that if we don't have the FFR, would we jump and do things to the proximal AD and left main? And we probably wouldn't. So I think that's one thing, and we're going to discuss the FFR issue also. But let me ask other members of the. Is there anybody that's doing FFR frequently in the AS patients at the time of TAVI? What do you think?
I don't agree. Even in this, would you please do the baseline angiography, Dr. Chung? Would you please give us some angio?
Yeah, baseline angio.
Yes.
Can you see?
A lot of some complicating situations. So if I were you, we just the little touch, very little touches of circumflex only. So what about those FFL values at that time was yesterday?
So yesterday, after finishing coronary angiogram only,
Yes.
I felt like only touching the distal circumflex region. But discussing with my team, the FFR should be done in this patient because proximal LAD and proximal circumflex region might be significant, even though it seems insignificant, maybe the intermediate region. But unluckily, the patient has very the severe FFR value under 0.8. So we are embarrassed. And we found, luckily, this year's TCT, last year ACC, some interesting report was, previous next slide. So is FFR reliable in setting of severe AS? Next slide.
Next.
Next slide is very interesting. If patient has FFR above 0.8, the value may not change very much. But patient has FFR value below 0.8, the FFR more aggravate after TAVI, after relieving aortic stenosis. So next slide. So the circulations, CV intervention also speculate increased pressure afterload and elevate endodynamic pressure and microartery dysfunction contribute more favorable FFR just before TAVI. So after reading this article, we confirm this FFR value is real. We have to treat the proximal LAD and proximal circumflex lesion. So our strategy in our institution is simultaneously perform the PCI and TAVI because we usually we didn't use a lot of contrast agent. Maybe the 100 we can treat the both three lesions, and then during the TAVI we mostly use the 50 to 20, so we can maximally limit our contrast volume on the 200 milliliter. So if patient is cerebral and very complex coronary artery disease, we usually schedule the PCI and then TAVI, but in this patient we decide simultaneous doing of PCI and TAVI. So actually we perform PCI.
Well, we better let you proceed because the time is getting short, so I'm getting a little nervous. Go ahead.
Yeah, okay. So panels, do you prefer pre-ballooning or direct implantation? So
So you are using an AL1 catheter, and then what kind of wire?
Yeah, AL2.
AL2, AL or AR?
Not AR.
Really a heavily calcified heart with very marked calcification, nicely crossed.
We prefer after crossing aortic valve, we use safari guide wire immediately. So don't change the pigtail, but sometimes we need a pigtail, especially in patient with small LV.
So this is a preformed wire manufactured specific for this TAVR cases. Its consistency is similar to an extra stiff wire. It's not a very, very stiff wire. And then it's nicely curved and sits well, and that's adverse events reported with this particular wire.
So we actually decided direct implantation without pre-ballooning because we have some experience. The patient with more calcium, more calcified aortic valve, we prefer pre-ballooning and implantation. But in this patient, the calcium, in my experience, it is a little bit not severe, not very severe, but moderate to severe. So I prefer the direct implantation. After then, we assess the hemodynamically and the angiography and T, and then decide the post-deal. Okay, we go ahead with TAVI implantation directly.
Very nice. Yes, I think that maybe if the echocardiographer want to comment on that, simply because there is a little bit of a sigmoid septum appearance with a little bit of a bulge of the upper septum. That is one thing that comes to mind. But otherwise, it looks you have a beautiful view that's perpendicular to the sinuses to work on. Yeah, go ahead and proceed.
Yeah, okay. So we already loaded valve. Just a moment. We have the inspection of the whether load is okay. Just rotate, and we confirm the pedal is okay. Very nice loading.
That's a nice trick. So you look at it under fluoroscopy just to make sure that everything is as it should be, huh?
Yeah.
So your pigtail is in the non-coronary sinus. That will not only will be used for injection, but also is a good landmark to show the lowermost portion of the aortic root.
So we are advancing. When crossing the aortic arch, we do the LAO and then tension on the guide wire, and then the valve not touch the arch, and then smooth.
So you are very careful not touching the arch so that to minimize the risk of stroke. Now, can you repeat once more what size valve you are putting in?
The 29.
29 millimeter valve.
Yeah. The LAO 11, cranial 10.
So maybe you can tell us as you do this, where are your landmarks and what are you paying attention right now?
Yeah, it's the pressure is blood pressure is okay, and we under the three-course view, you can see this is three-course view, and then we change the direction caudally. Caudal. You can see one straight line.
Yeah, the
Can you see?
lowermost portion, yes, that's the opaque portion was somewhat oval. Now it's straight, but that means that we are looking perpendicularly.
Pardon?
Yes.
Yeah. Can you the implant right now? Okay. So we just did some discussion. Or?
Yeah, I think that you're in good position. Your
Yeah.
blood pressure is coming a little bit softer.
Yeah. So this is actually the depth is 3 point. Depth target is 3 to 5. Now we start. We don't need pacing.
So you're just below the annulus, starting
Yeah, just below,
beautifully.
yeah, just-
Okay. And you let the valve
Just
to be
movement.
exposed.
NGO. Yeah, a little bit.
So pigtail moved up.
Yeah, pigtail. I deposition pigtail again.
There's quite a bit of angulation. Do you anticipate any problems here trying to get coaxiality with this valve? I think that might be one of the challenges here.
와이어 가이드예요?
Yeah, that's an important point that Dr. Walters brought up, is the sort of somewhat of a horizontal and angulation in the LVAO direction.
Yeah, the patient has a little bit the horizontal aorta, so the first of all, the implant like this, and then the NCC side very high, and then RCC side deep in the LV, and then after 80% deployment, I change a little bit the layover, so the valve is maintain the coaxiality after layover, so we can decide after that.
So you're going to implant very shallow on that non-coronary cusp and then try and lay it over.
Because she has some the horizontal aorta and the less coaxiality right now.
Yeah. That's a problem for paravalvular leak, because if you really don't get that good coaxiality, you'll end up deep on the left coronary side with a leak around that portion of the valve. And this is one of the issues with self-expanding TAVI, in that it can be very hard in a horizontal aorta like this to maintain coaxiality and to get the same depth of implant right across the annulus. And of course that precipitates problems with paravalvular leak. Sometimes this can be corrected with using the balloon expandable platform, because it will tend to center itself and you can use a retroflex catheter to get better coaxiality. The other thing that can centralize better is a top-down deployment, like with the cementus valve. But the layover technique is particularly used in the Lotus, where you deploy and then you push forward and pivot. And that can help get a better coaxial valve.
How do you think about that?
That looks pretty good. Yeah. Don't go any further down, I suppose.
You can see that we've triggered some heart block there, and that may be, some pressure on the conduction system and the non-coronary cusp. So even at this point, manipulation in that region can cause temporary heart block.
Okay.
I think they stay pretty good right under the annulus, quite shallow.
Yeah. The bradycardia is actually working for you, really. It's giving you the time to deploy. You You can see this problem here where on the left coronary cusp you're quite a bit deeper than you are on the non.
At this moment, I will do the layover. After then, we decide.
Yeah.
와이어 좀 조금 밀어줘봐.
So your valve is functional there, and you still got it captured. So you could recapture it if you had to.
So you're just pushing your catheter in order to get it to the greater curvature, with the hope that this will lift up the left corner sinus site.
It's a little bit deep.
The only problem with that strategy with a core valve is it may force the non-coronary deeper, and it may not pivot if it's trapped by the calcification.
Even though I started the NCC side very shallow, the final the relative deep, so I start recapture and repositioning again. Do you agree, or do you think it's okay?
Well, the question I want to assess is, do you have any paravalvular leak?
Unluckily, patient developed the complete AV block, so we stop and then recapture.
Well, any other comments from the panel?
Maybe if we can push the wire a little bit more, maybe the valve will go up a little bit.
Yeah, I agree with Kantaro. I think the level of the valve is good, and we know that at the end it will move by 2 or 3 millimeters. So I think at the end it could be perfect if you deploy at this level.
It's difficult to be for sure, but it doesn't look like the AR is paravalvular leak is horrible. And then I don't know if you can do this better, because you're going to start pretty much as shallow as you started. So I would also think that you should go ahead, perhaps.
Yeah.
The only thing is to apply some pressure.
We are doing recapture.
Yeah.
So if there's no AR and you've got toe, I would probably have left it and deployed.
Oh, okay. Just a moment.
Oh, you decided to recapture. Okay.
Yeah, recapture. Yeah, test it.
So of course you can play also with
we start
that particular
this
wire.
portion.
Be coaxial with orifice.
So you moved it up even more. You're just by the annulus, actually. And then now redeploying.
Yeah, redeploy. Just a moment. Stop. Test it. Oh, okay.
Yeah. You're just barely in the annulus. That's as good as it gets, probably.
Go ahead.
The risk starting this high is a pop-up, of course.
Okay. This
You should push hard at that time.
Sometimes you can start being more coaxially by putting on the larger curvature and then applying pressure on the wire just to stabilize the valve.
Okay.
That required quite sensitive cooperation between the two operators. Yeah.
In the first case, it looked like the central leak was there, and now it looks more like PVL on the left side.
I think the position is a little bit higher, maybe 2 millimeters, and I think it's enough. If you try to be higher, it will be very difficult.
Yeah, that's not much of an AR, it looks like, huh?
Yeah, it's not good. That recapture again.
Again, if there's no AR, I'd probably deploy.
Yeah, I think that I don't know if you can get better in this, huh?
It's just a problem with the technology, I think, in the way the self-expanding valve works.
프레셔 올려주세요. 네.
You often end up, non-coaxial like that.
Yeah, in this patient, coaxial is the problem. So my strategy in this patient, the NCC side, zone 0, and then the pacing 120. After then, later time we lay over and then see what happened. Let's go. One more. Yeah, okay. 자, 와이어. Okay. 자, right now the 110 facing. Start.
So, is there a limit, do you think, on how many times you can recapture?
Pacing is not working.
3 times. 110. 110. 자, 테스트.
Of course, the company will always say 3
facing.
times.
In
자,
one
지금
case,
괜찮아요?
after fourth attempt, we had to remove the valve. It was not working
자,
properly.
testing.
So
Okay. 자, go ahead.
What about the risk
Slowly.
of stroke after multiple
Slowly.
captures?
Slowly.
Theoretically raised.
Pitching.
There's some pressure down now.
Yeah.
You don't want to pop out.
자, at this moment, I like prefer the
Yep.
We analyze
okay.
our experience
자,
with
facing.
recapture.
자, testing. Okay.
Yeah.
Okay, a little bit better. Little bit better.
I think
자, NGO. 자, facing off. Facing off. 자, little bit better.
So the pacemaker is not in the right ventricle, that's why it's not working.
Yeah, pacemaker is not working.
Popping.
How do you think this positioning?
I think
in
this is
patient?
by far the best one and as good as it will get.
Yeah, okay.
Yeah.
Cannot be better.
Show angiogram again. Angio again.
What we did notice
Okay.
with repositioning
Yeah, push the guide wire a little bit.
is
guide wire,
that
push it.
acute kidney injury is more common. And that's because you
Yeah, okay.
have a greater
자,
contrast
just
load.
slowly.
You know, I think this point is extraordinarily important, particularly in this case where we received 100 cc yesterday and then coronary interventions and
Just
on
moment.
top of this, this
Just
contrast. And some hypotension. That is not the best
I'm
friend
doing
of
the
kidneys.
release, final release.
Yes.
The wire tension is reduced, and then I push the valve.
Pigtail.
Okay, I'll do angio again. Okay, perfect. What's your opinion about this? Just when I managed the
I think that this is a
pacemaker.
case that you can call it done once you get the pigtail out, because you probably, unless there's a lot of AR that will respond to
I know.
post-dilation, you wouldn't think to post-dilating this valve with this kind of very shallow implantation.
Yeah, because this patient has coaxial problem and complete AV lock, even though the
Exactly. If you
it's a very difficult case.
But very well done.
I think the best you can get, this is an anatomical issue. So retrospectively, do you think this is the type of valve which, what's the best valve for this kind of anatomical issue?
Yeah. Let's hear from our T specialist, Dr. Chung.
What do you think is?
There is some paravalvular leak at the site of commissure of LCC and NCC.
So there is a little bit of paravalvular leak, that's right, but can we see the hemodynamics on the left upper panel?
Just a moment.
Yeah.
Yeah, pressure is coming back. 160 to the 50.
You still have a wire in the LV, right? Can you put a pigtail? We see the simultaneous pressures that give us a better sense of
Okay.
AR. So how much, I would like to hear from the panel, what is the opinion of, when you assess the AR, particularly in this age of minimalist, what do you use? Do you use just aortography or do you use hemodynamics, Alan?
First, hemodynamic, the level, of course, of the diastolic pressure and the shape of the aortic curve, and then angiography.
Okay. Do you always get simultaneous pressure tracing? No. You don't?
No, no.
I think if you have a good echocardiography after deployment of the valve, including transthoracic echo, you can really assess, in the majority of cases, aortic regurgitation, more than grade 1 or not. Sometimes you should use hemodynamics sometimes, but in the majority of cases, good EDT is enough.
We generally use hemodynamics heavily because it's cheap and it's very quick. Just putting a pigtail catheter in and taking the wire out also improves the transvalvular appearance also. So the different practices.
I have a question about ACT during the procedure. In my center, we always check ACT before implanting the valve, just to be sure that we are really on top of good anticoagulation. So what is the opinion of the panel?
Yeah, we always check that as well at ACT because requirement for heparin is different from patient to patient. It's really critically important. What was do you check the ACT in the lab?
ACT, we checked the ACT. It's more than 300. We didn't give heparin. So unluckily, the guide wire is just next to the strut. So when you cross the valve,
I wouldn't spend too much time in there.
It may be damaged.
Position. I don't know.
You should push the wire in order to have no problem with the core valve, because you see there is some interaction between the core valve and the wire.
Yeah, I think
so if you push the wire before pushing the catheter.
It's dangerous. To do.
You just want to make sure that you don't get tangled up there when you're taking your wire out also.
Just a moment.
I think it's very important because if you remove the safari wire without protection, there is a risk of embolization of the valve.
Okay. We remove the supply wire and then change into another wire.
Dr. Chang, you better use exchange the soft wire.
Okay, so we are.
Okay. I wouldn't go back in, right?
Just when we the implant view. Implant view. Not implant. Three cusp view. Cranial 10 area. So cranial 10 area. So actually, this is three cusp view. So I'm doing the aortogram. Yeah, no PBL. Actually, the depth is ideal.
Yeah, very well done. It was a very difficult case. You really stayed with it and recaptured twice. And I think on the third attempt, you implanted very shallow. We congratulate you, and I think
that the last question will be the policy on leaving the pacemaker because the patient.
Third-degree block.
Unluckily, she currently not recovered to sinus rhythm, so we have to keep the pacemaker. But probably the depth is very shallow, so I hope the recovery of AV blood will happen within several hours.
So when patient had a very early complete heart block, even if he recovers later on, how long do you keep the patient in the hospital? It's not very easy to decide to send these patients home, isn't it? Because the AV block occurs so early and then maintained throughout the procedure. I'm not sure that if we can let him go without a pacemaker.
I think he will get a pacemaker, no?
Yeah.
Because he had the AV block, yes, as you said, very early. And why wait with a pacing lead for 2 days?
Right.
I think.
Any for this self-expandable, any chance for the recovery? I saw there's a pretty small chance for the AV block with this kind of.
Yes. Any comments?
Yeah, I mean, early heart block like that almost always results in a pacemaker. And if you follow these patients up, a lot of them are not using their pacemaker down the track. But it's impossible to predict. So you find yourself implanting pacemakers in these patients.
Yes. Well, thank you very much for a wonderful case, very educational for all of us. Thank you indeed for your expertise.
Okay, thank you for sharing case with me. So it's the first time I do the 3 times of recapture and repositioning, but very interesting case. It's very useful to me and our team. Thank you. Thank you very much.
Thank you very much.